Thank you all. So we now have Dr. Bill Morris, who's going to join us to talk about opioid failure, and I think the concepts will dovetail really well. Okay, so there's your mic, and there's your clicker.
So it struck me, that's kind of sorry, my voice is a little hoarse today, but it struck me as I was driving down from Santa Cruz today and going by the fields and realizing we were coming to the Steinbeck Center. It really struck me, you know, it's a perfect and actually a good place to give this talk. You know, Steinbeck, I think what I loved about Steinbeck was his writing about people, especially, what was that, Cannery Row, the book Cannery Row, where he talks about all these characters that are they all have some flaw and some defect, and yet they have a community and they come together, which I really think is important to think about when we take care of this patient population, because they do tend to come from very difficult backgrounds and are challenging in how we care for them. I mean, they can tire us out. And I think one of the things that we have to do, and I was thinking about my opening remarks from my talk, if we're going to take care of these patients, I believe we have to have at our core a sense that everyone has a value. Every person has the same value. And it doesn't matter if they're driving you crazy, if they're on opioids. And one of the things that hearing Anna talk about, you know, in watching her videos, one of the things that I think is very natural to do is when we come into these difficult situations, we try to go away. I mean, what is writing a prescription for a patient and just giving it to them, then trying to run away from their pain? Because it's our pain too. We're trying to run away from our pain about dealing with these patients. And what we really have to do, just like we have to model for our patients turning towards their pain. And we have to turn towards our patients' pain and our own pain in dealing with them. So that's sort of my opening remarks. So what do we want to talk about today is to try to talk about this idea of opioid failure. And I thought that we'd talk a little bit first about events that happened in this last year, these publications that came out. And if you're here, you're interested, I think, in this whole area, and I'd encourage you, if you haven't read these documents, they can be somewhat long. The CDC guidelines has a nice summary of 12 points, and then the Surgeon General's report on addiction in America, I think, are both very good documents to review and to think about. Okay, so I'm going to talk about those briefly. And then I'm going to spend a lot of time sharing about the work of our SafeRx coalition in Santa Cruz County, where we brought together a lot of different people funded by the California Healthcare Foundation to talk about the idea of how we can improve on opioid safety. Over the last year and a half, we've been doing that. And we're running to the end of our grant, but we have a little more money, so we're going to continue this coalition's work. And core of our coalition's work is this concept of opioid failure. You know, I think it's important, you know, if you don't really have a definition of something, it's really hard to identify it and to recognize it when you see it. And so I think this is what we worked on with opioid failure, coming up with a fairly simple working definition that will allow us as practitioners and clinicians, whether we're in healthcare or counseling or supportive services, addiction services, to identify when opioids fail. And one of the things that the coalition has been very, I think, in agreement about and firm about is that opioids fail, not our patients. So we can focus on that concept. You're not failing. Opiates have failed you, so let's talk about a different path to take since opioids seem to have failed you. And then talk a little bit about how we might manage that failure. Dr. Lemke talked about opioid failure management to some degree already, but you know, there's other things that we can talk about too. Weaning is one of the paths we can take. So the CDC guidelines came out in March of last year. I mean, they were not without controversy. I don't know, there was you know, a lot of public comment that came out on the internet after they were released, and they went through a revision. And you know, there are a lot of people who don't necessarily like them too much, but I think they're very helpful. And they really encourage us to try to think about, and sort of this prevention, trying to avoid putting people on opioids to start. I think also it's helpful in that it tells us, you know, if you get people on opiates and they're not doing well, and since opiates have failed, it encourages us to talk about getting them off. And they gave us some thresholds that I have found very helpful. I mean, they're a little artificial. You know, are they based in data? Well, I think they're more based, don't you think, Dr. Lemke, more on clinical experience and intuition. They weren't based on a lot of good research data that, oh, if you get to 50 milligrams of morphine equivalent per day, that, you know, you're in trouble, or 90, you're in trouble. I think they had to balance the experts that came together to do these guidelines. They came together and talked about, okay, when is it that benefit starts to decline and risk starts to escalate? And I think they found there is some data to suggest that this happens at around 50 and then certainly at 90 milligrams. So this has been very helpful, I think, and it should be helpful for all of us to keep in mind. I think it's helpful to take your patients that are on chronic opioids and have in a sense in your mind how much morphine equivalent per day they're on so that you can then take the steps to have the conversations. And that Bravo acronym that Dr. Lemke proposed, it's when are you going to have that talk? When are you going to start to have that talk? And I think you can start to have that talk when they start to go above 50 and opioids look like they're failing. All right. And then the second report that came out from the Surgeon General in November of last year, it really was the first time, sort of like, when the Surgeon General had a report on HIV/AIDS. This was a very groundbreaking landmark discussion, even though, addiction has been a huge problem in the United States for a long time. First time the Surgeon General really talked about it. The incidence, as the slide shows, is as great as diabetes in this country, and greater than cancer. And the other thing was to put it in the context not of a criminal justice system, which we have for a long time, but in the context of public health. How do we improve public health by addressing this? And it's been encouraging, or at least it has been, hopefully we'll see what the future administration right now goes forward with, but to have parity with healthcare, mental health, addiction services. That's really encouraging, I know, for all of us in addiction services, to really say for the first time, we can start to say, yes, you should be able to get the same sort of treatment that diabetics should get, or hopefully, ideally, will get for their care for your addiction. And encouraged us to really talk about thinking about how do we learn more, how do we educate, recovery support, and where do we go forward in terms of research. I mean, we heard from Dr. Lemke, a lot of stuff was done with chronic opioids without a lot of data behind it. And I think it is important to acknowledge that to our patients. And again, it's sort of turning into the pain and saying, look, I'm sorry, we did this to you. And patients will say that to you, right? They'll say, why did you do that to me? Why did the healthcare system do this to me? And we can turn and say, I'm sorry that we did that. Let's move forward now. Let's try to make a difference. Let's try to take a different path. So really this struggle, this challenge, for some patients, I think we all would agree, opioid therapy can be an effective chronic treatment. We don't have data for it. We don't know what % of patients with chronic pain that get on chronic opioids it helps, but certainly it does seem to help some patients, okay? But how do we safely continue to prescribe for those patients? How do we monitor? And there are guidelines out there, and I'm not going to talk about that today. What I'm going to talk about more is how do we recognize and manage those for whom it appears opioids have failed? The opioid legacy patients that they've been called sometimes. They show up, or you've inherited them, or you've done it yourself. I've certainly put patients on high dose of opioids. We're always very sensitive about allowing, all these guidelines that come out. This is not for palliative care patients. This is not for patients that have a terminal disease. But I tell you, I do palliative care work a lot. And as we see longer and longer survivals for cancer patients, this is a problem for our cancer survivors, and we've talked about that in our cancer center. I had one patient, this is an amazing story. He was getting methadone for a nasopharyngeal cancer that he had gotten treated for, gotten on high doses of methadone. And he saw me in palliative care, and I continued. Obviously, I'm going to give him methadone for his cancer, but his cancer was in remission, but he had a real difficult psychosocial situation, didn't finish treatment, and so it came back. And so we were prescribing methadone. We had to escalate the dose. And, we followed him, got him onto hospice. Eventually, he died. And then a year later, we were remodeling the suites in the palliative care center. And so they were pulling the desks away from the wall. And behind one of the counters was this sheet of paper. And it was this list, to-do list. And it was from my patient. I know it was. It said, number 1, see Dr. Morris to get methadone. Number 2, sell methadone. He actually wrote that on his list of things to do. And number 3 was pay Tom the money I owe him. So, here was a patient that, did I contribute to maybe a lower quality of life at the end of his life? Or maybe I guess I contributed to a better quality of life. He had money that he could pay back Tom. But just because he was palliative doesn't mean I shouldn't have sort of asked the question, have opioids failed this patient? Because it does happen, as we see. The other thing I'd say is, as we did outpatient palliative care in Santa Cruz, I started to realize that, cancer care has really come a long ways. I mean, the patients that I see in the hospital in palliative care are ones that really are at the end of their life. Palliative care is really important, but outpatient oncology, patients really thrive and do well. And so we have to ask the question. I think we shouldn't always give a freebie to these questions that we're asking today for patients just because they have cancer. Okay. Because really it is how do we improve someone's quality of life? All right. So in Santa Cruz, we certainly have a problem. I think we're one of the higher counties in the state with regard to deaths related to drug-induced overdoses. So compared to the California average of 3.8, we were 19.2 back in 2016. And our coroner, actually, I'd like to say our coroner is doing a great job looking at the data, collecting information about patterns, where patients got the substances, were they prescribed, were they gotten on the internet, were they bought on the street, what other medicines were mixed in, because a lot of these deaths are mixed medicines, right? They're benzodiazepines and prescription opioids and methamphetamine or something else. So I would really like to support, continue to support and have you encourage the coroner to continue to do this, because as you understand these patterns better, we'll be able to address issues that come up.
Does that include alcohol?
Alcohol does not include, although some of these patients who died with drugs have alcohol in their system as well. But about 3/4 of these were related to prescription drugs. 3/4 of these deaths. So there were 19.2 deaths. And you've heard the statistic, 50 more or less deaths occur in the United States every day from drug-related misuse or use, proper use. In Santa Cruz, in PAMF, where I work, we have what's called an opioid users shared medical appointment, where we're trying to get all the primaries to send to it's an hour and a half shared medical appointment, group appointment, where we talk about the risks of opioids. And patients, usually, there are always a few that sit in the back with their hands, arms crossed, and they're sort of bugged that they have to come because their doctor told them you have to come. Yeah. Oh, switch. Okay. And they would, and they're saying, I'm not going to overdose. Including a few intentional overdoses, but most of these are unintentional. And that's what I say. Most people don't wake up that morning and say, I'm going to overdose today. They're taking their medicines like they're supposed to. Now they often end up in a cycle of disability and symptoms. They can't sleep. They're depressed, and so they end up getting more and more medicines layered on top of their opioids, and the combination of all that happens, and they die. A lot of these patients have sleep apnea. A lot of these patients have other problems, psychiatric problems where they're on psychiatric meds as well. And so all these medicines combine top of sleep apnea. They get a little older, your COPD gets a little worse, your kidneys don't work as well, and then you die. And so we're trying to address that. So really the question that we need to ask ourselves every time we have a patient on our chronic opioids is, do the risks of opioids outweigh the benefits? If so, maybe opiates have failed. And so that's the key question we have to ask. So what we did in Santa Cruz was about 18 months ago, we got some money from California Healthcare Foundation to form a coalition. And the coalition really was supposed to address 3 major areas. The first was safe prescribing, and that's talking about giving opioids to patients who seem to be doing well. They're meeting their goals of care. And how do we do that safely? Okay. Second thing was to increase access to medicated assisted treatment, whether it's methadone or buprenorphine. How do we improve access for our patients? Patients, I think, come to see me a lot and say, boy, I wish I'd known about other treatments. I think often we keep giving patients opioids because we don't really have any other option. We don't have anything else to do. And so we often keep giving them the same medicines because we're sort of helpless in that way. So if we increase access to medicated assisted treatment, we might be able to then make some transitions. And patients, I'm surprised, actually I tell you, I'm surprised how often patients will say, yeah, that sounds good, I'll do it. I think, in my sense, is that more patients have given an alternative to chronic opioid therapy in a safe and supportive environment. Not, we're going to cut you off, you have to figure out what you're going to do, but this doesn't seem to be working. Opiates seem to be failing you. That patients will choose that alternative path. Maybe not that same day, but they'll start to think about it. I have patients that call me 6 months later, we talked about a different path, and then they said, let's do it. I want to do it. And it surprises me. Again, these patients, the core value of these people, these are survivors, and I tell them that. And sometimes they'll cry when I tell them that. I say, you are a survivor. We talk about narratives. Anna talked about narratives. We have to tell these patients a new narrative. What's the narrative that they've heard for a long time? You're useless. You're disabled. You're an addict. Family members tell you, what do you doing with your life? You're on disability. You're a freeloader. So these are these narratives that these patients have learned to hear and accept for themselves. And what I think we have to do, one of our jobs as clinicians, is we have to help them together with them come up with a new story that they have to tell themselves. I don't know if any of you read Anna Lembke's book, but she tells a great story about a patient who struggled with alcoholism and got sober. And for many years did very well, but then had a problem with his back, went to the ER and got a shot of an opioid and said, wow, this is really good. And instantly was going down the path of substance use, opioid use disorder, and addiction. But now his story, before his story was, you're a deadbeat alcoholic. And the story was, I'm clean and sober. And then his third story, which is probably one of the hardest stories to break, was, I'm a good patient. I'm taking my medicines as prescribed. And by the way, it really makes me feel good, even though all I do all day is sit on the couch. So it was a story that was a lot more socially acceptable than alcoholic story. So we have to change the story to, I think, you're a survivor. You're a strong survivor that hasn't had any other options. And now we're going to give you another option. And because you are a strong survivor, you're going to take this option, aren't you? I think that's the story we have to start to tell our patients. And then we have to make sure that we have another option to give them. All right, this is the coalition of members so it's a really widespread, do you have one of those? Can you bring one of those up? Oh, okay, Ryan is holding up, there's one. Ryan is holding up one of the things that was produced in the SafeRx, and I think they're at your tables. If anyone would like some of these for their offices to put out for patients to pick up. This is sort of a way to really empower your patients, okay? It says, feel better. Patients go, I want to feel better. I have chronic pain and I don't really feel that good, even though I'm on high dose of opiates. So they pull this out. And really what it talks about how, understanding opioid pain medication, talks about the risks, names some of the opioid medications that patients might be on, because they may not know what opioids are. And then it talks about, there's no magic pill to control your pain. Talk to your doctor. Again, this is a way of starting to get them interested in a different story about themselves. Okay? Talk to your doctor. I think I'm convinced more and more, it's great to talk to all of us as providers, but I'm more and more convinced that in order to be effective in making a change in how we prescribe opioids, especially for the legacy patients that have been on high doses of opioids for a long time, we're going to need to go to the people and teach them, look, you need to demand from the healthcare system that there's a better alternative than high-dose opioids for chronic pain or chronic opioids for pain. They're going to have to demand that we do things like good physical therapy, all the things we're going to talk about on management of opioid failure, alternative therapies, ways to get off opioids, So these are nice to put out to sort of start to stimulate the discussion, to get your patients thinking, I have a different story that I can follow. So this is the definition of opioid failure that we came up with as a group. We got together representatives from the coalition members, and we sat down and we talked and we said, well, these are the 3 questions really you need to ask about a patient that's on chronic opioids. The first is, are serious adverse effects occurring? And what is a serious adverse effect? Well, we sort of said it would be if you're dying, if you're going to die potentially from this, or you can't manage it. All right. Second question would be, is the patient using the opioids appropriately, or is inappropriate use occurring? And this is a harder question to ask, because it has a lot more judgment. If someone gets hospitalized with respiratory failure on opioids, and everyone in the ICU after they've been extubated says this was related to their high-dose fentanyl patches, it's pretty easy to say that adverse effects are occurring. But the fascinating thing is there's actually been studies out there that show that when that happens, 6 months later, patients usually get dropped on their opioids. They often don't get taken off of opioids, but their dose drops, and 6 months later, they're back on the same dose. And when I see patients at Dominican and I say, look, we can't continue opiates for this patient. This is bad. They almost died. You saved their life. Great. But now let's talk to them about getting off. And then what's the response that the doctors tell me? What do you think? Well, they're going to come right back, but they say, what are we going to do about their pain? That's what their question. They're frustrated. What do we do about their pain then? So, and patients often, when they get to that point, often don't really want to talk about coming off of opioids, but sometimes one guy told me, I'll die if you don't give me my opiates. And I go, well, but you already almost died, on your opiates. So this is not too different. And it's not really, you have a better life, believe me. And so it takes some convincing. But someone like that, you really can't send them out on their same dose. Okay, is inappropriate use occurring? This could be anything from diversion, selling on the street, like my nasopharyngeal cancer patient, or it could be on sort of the other spectrum, loss of control over your substances, your opioid, or opioid use disorder addiction. And then a lot in between. Like Anna said, there's a lot of misuse that occurs that isn't necessarily straightforward and clear addiction. And how much misuse counts as opioid failure? I think that's a judgment that we have to use as clinicians. If every time they come in, they're focused on getting their prescriptions a little early, or they want to go up, or they're always causing problems in the clinic around their opioids, maybe that's opioid failure, because it's just not working. The risks are too high. The risks outweigh the benefits. And then third, only third, I think should we ask, are the treatment goals being achieved? Okay? What would you think of a doctor who, let's say someone came in and they had a horrible or like a pneumococcal pneumonia and looked horrible. Oh, we want to give you, and we're going to give you some ceftriaxone. And the patient says, because ceftriaxone certainly would work against this, this pneumococcal pneumonia. Let's say they were able to take a little sample of the sputum and grow up, and it was culture, and it was sensitive. So we knew it was going to work. But the patient said, I get anaphylaxis when I get ceftriaxone. And if the doctor said, I don't care, I'm going to give it to you anyway, we know it's going to work. It's working. It'll work. So I think that's why we have to ask first, are adverse effects happening? Are inappropriate use happening? If the answer is no to those, then the third question is, are we doing what we're supposed to be doing? Not only analgesia, but I think as we're all learning, and I certainly had to learn in the last few years in my palliative care practice, it's not just about analgesia, it's about function too. We can make someone comfortable or reduce their pain low enough, but they may not be able to do anything. In palliative care, we have this thing called palliative sedation, where patients can't have their symptoms controlled any other way, we just put them to sleep. Because they're usually at the end of their life, and if they're having uncontrolled pain, we can just sedate them with some Versed, and they're not awake. Obviously that's not the appropriate response for someone that's going to live 20, 30 years with back pain. But that's why we have to realize it's function too. So function is bad. Analgesia sometimes isn't not that good, but function is good. That's pretty good. That might be what we want to do. All right. And has there been an adequate trial? I think we added this, again, out of trying to be fair, trying to say, okay, for some patients, maybe chronic opiate therapy works. And, in our PAMF shared medical appointments on chronic opioid use, the first thing I tell our patients, because they're all worried we're going to take away their opioids. And what I try to reassure them is, for some people, chronic opiate therapy may work for their chronic pain. We don't want to take away your opioids. We want to do it safely. That's why you're here to learn about the risk. But for many people, probably the majority, chronic opiate therapy won't work. And we have to recognize when that happens. So it reassures them. But what is an adequate trial? We'll talk about that. Now, a lot of the adverse effects that we know, at least in literature and science, came out of this, summarized in this 2015 NIH Pathway to Prevention workshop where we looked at chronic opioids. And they showed that certainly overdose happens, abuse and addictions happen. Myocardial infarction was noted to be increased when patients are on chronic opiate therapy. That was interesting. And then certainly motor vehicle accidents, which is sort of a change. I remember it was about 10 years ago, we used to say to patients, You know, if you're on a stable dose, you should be able to drive. But we're getting away from that, and we're saying more and more that, you know, any dose probably you're going to have less safety than if you weren't on opiates. The higher doses, we know from Canada databases where they have a pretty good ability to look at motor vehicle accidents with dosing because they have a national healthcare system. They find that the higher dose of opiates you're on, the higher your chances of getting into a car accident. So I think we have to start educating our patients that driving, you know, as hard as it is to say, driving on these opioids, really you should be careful. You could be arrested for driving under the influence. And the hard part is, you know, you have chronic pain, chronic opioids, you may not sleep very well. So you don't, maybe you're, you know, and we know that bad sleep leads to more accidents too. So you might get into a car accident or get pulled over because you didn't sleep very well. But because you're on opioids, if they find it in your blood, you might be or legally liable. So it's important for them to know that. Okay. The recent law that passed that says we, as providers, we all have to check the cures for anyone we prescribe opioids to came about because the legislature's family members died in a car accident. And the person who caused the accident had been given opioids by a number of different providers, and no one checked the cures database to see that. So, you know, clearly there are consequences. Now, we all see patients in our practices that have horrible GI problems. I think that's one of the biggest complaints that I see in terms of adverse effects, this narcotic bowel, chronic pain. It's almost like a super irritable bowel that we see. It's often not attributed. I see patients who have gone to GI doctors and they're given, you know, the Movantik, the new drug that's really expensive for opioid-induced constipation, you know, that makes more money for the pharmaceutical companies, and they cause one problem, and then they give another drug to solve the problem with the first drug. A friend of mine went to England, and they said, what are you taking this Movantik for? Just take a good dose of castor oil. That's the practical, you know, of the English healthcare system. But so, you know, GI problems, cognitive, psychological problems certainly occur, and patients don't have the ability to see it. So one of the things we were talking about the other night among the speakers was it's probably really important when we do an assessment to ask healthcare or ask loved ones, significant others, how is your loved one doing? And patients, I've had this experience where I say, do the opioids ever affect your ability to interact or to talk or to, you know, are you sleepy on them? And the patient's saying, no, doctor, and behind them their spouse is saying, you know, nodding head yes, and they don't want to say it, but it's there. So it's helpful to get second opinions and, you know, confirmatory input about that topic. Often patients too will say, after I've gotten off my opioids, or families members will say, thank you for giving us our loved one back, because it wasn't really even noticed until we got rid of the underlying opiate. Infections, it's thought that opioids chronically can suppress the immune system, but we don't really have a lot of good evidence about that. But certainly falls, you know, patients, I ask about falls, do you fall often? And they'll say, oh, yeah, I fall, doctor, but it's because I hurt, because my hip is sore, or my knee is sore, or something, but, you know, maybe it is, and maybe it's, you know, the opioids are slowing down your response time. But those are things that are clearly could add up to an adverse effect. But I think this is really probably the biggest one that I think I'm more and more appreciating, because I'm looking for it. Again, if you know about something, you look for it, you see it more often. And that is opioid-induced hyperalgesia. And it surprises me how often patients know about this now. They're starting to say, yeah, I think I have this hyperalgesia thing. But often, too, patients are very surprised. You mean the opioids that I'm giving can make my pain worse? And the way I explain it, you know, we have scientific explanations about why it might happen, the spinal dynorphin, descendant facilitation, you know, all the complexities of our nervous system. But what I tell patients is, you know, we all have to feel pain. Remember, back to stories. We got to tell a story that makes sense to patients, and just as like we want to tell a new story about their strength and their ability to come off of opioids. So the story I tell, just like Dr. Lemke gives the story about the gremlins, you know, I say, okay, we all have to feel pain. Pain warns us about bad things that happen to our bodies. When something's wrong, we need to know that. So we can trick our body with opioids in the short term. No one doubts that. Morphine, a shot of morphine is great. Prevents the pain in the short term. But if we keep trying to trick our bodies are really smart, and they will evade that blockade and go around it and increase the sensitivity. And there's actually been studies where, you know, we put volunteers' arms into a bucket of ice water, and they measure how long you can keep that arm in that bucket of ice water before you have to take it out because it hurts too bad. And there's been studies that show that if you do that, get a baseline time, and then you give them opioids for a month, And I tell this to the patient. I tell them this whole research study. If you take that and you give them opioids for a month, the amount of time that they can keep their arm in the bucket goes down. And they sort of look surprised. You're on this chronic, powerful pain blocker, and your ability to tolerate pain goes down. And so patients know that too. I tell you, the biggest wimps of all are patients on chronic methadone in the methadone clinic. That when they go in for a dental extraction, they have to be on OxyContin, for a couple of weeks, right, counselors that are here? I mean, they really have a hard time dealing with other pains, even though some of them are on 200 milligrams of methadone a day. And it's helping them with their addiction, but it also is probably increasing their sensitivity over time. All right, so second thing, and the only way we really know sometimes that someone has hyperalgesia is we get them off opioids. And I've had it happen where someone's on huge dose of opioids, we get them off, and their pain is now manageable by Tylenol. Patients never believe that when I tell them that, but it's happened. Again, anecdotally, but not scientifically. Is inappropriate opioid use occurring? Now, the way the committee looked at this was to say, okay, let's come up with a pyramid, where there are a couple things at the top of the pyramid that clearly we have to say opiates have failed, based on this criteria. And that is if you're doing something that causes you an acute risk of danger, of harm, life-threatening, illegal activities, and if you clearly have an opioid use disorder, okay? So this might be the person who continues to drink multiple 4, 5, 6 drinks a day despite being on high opioids. Opioids have failed that patient. It's aberrant behavior and they need to come off of opiates or stop the alcohol. If they won't stop the alcohol, then they need to come off the opiates because you'll kill them. But then there's all these other things, all these tiny, lesser things, lost, stolen prescriptions. How many lost, stolen prescriptions before you fulfill this criteria? I think, how many times do you have to ask for an early refill? How many times do you have to switch doctors? How many times do you have to, go up on the meds on your own without talking to your doctor? How many times do you have to admit that, oh yeah, I saved the extra ones, I hoarded the medicines that that I didn't use this month because who knows when we're going to have another earthquake, and I want to have access to the Percocet and the Norco that I normally take because I wouldn't be able to come in and see you. And that happens all the time. I would encourage you strongly when you see your patients to really go over how are you taking your opiates, because when I see patients in a clinic and we address this problem, let's say they may be written for, 1 Norco every 4 hours as needed. And they might take 2 in the morning and then not take any for all day when you ask them, and then they take 2 at night. So they take 4 a day, but it's not really taken as you thought it was being taken. The other thing that happens a lot is, these patients that are on as needed really are taking them routinely, aren't they? I mean, every month they go through their full supply, and the only way they're going to do that is they take them routinely. And so I think it's better to say, in those cases, switch them to routinely. Say, this prescription is 90 Norco a month, and you can take 3 a day on average. And some days they may take 2, other days they take 4, but in reality, they're taking them routinely. So you have to use your judgment. How many of these have to be met really before opioid failure is felt to have happened? Okay. And this is sort of the sphere of patients that we have, chronic pain patients on opioids. And like Dr. Lemke said, a good percent of these, 30, 40% have aberrant opioid-related behaviors. They're not quite opioid use disorder addiction yet, but they're misusing them and they're headed towards maybe addiction if nothing changes. And I would estimate, I'm a little more optimistic about addiction. I don't think it's 10 to 15 like she said. I think it's probably around 5 that really clearly have a severe opioid use disorder. I mean, if we define addiction as, these C's, these 3 C's or 4 C's, impaired control over drug use, compulsive use, to me, continued use despite harm, and it reflects a loss of control. And then craving. Not many of my patients will say, I really crave opiates, because they know that's a bad sign to say that. But after you develop a relationship with them, sometimes they'll say, I really miss my Norco. Let's say I've switched them to Buprenorphine. I really miss my Norco in the morning. It came up the other day. We were talking a little bit about this with Gabe, the next speaker. Some patients, when you give them Norco, isn't it interesting? They say, oh, it really energizes me. It makes me feel better. It energizes me. And other people, really, when they take Norco, it makes them sick, makes them feel lousy, they're really, I don't think, at very much risk of developing an opioid use disorder. And probably we think when you look at the registration trials and pharmaceutical companies have to do to get these medicines approved, really about a half to 2/3 of patients stop taking their opiates because they don't like the way it makes them feel or it doesn't help their pain. And then you get this group of maybe a third of folks that continue to take these medicines, despite maybe not needing it anymore. So these are the DSM-5 opioid use disorder criteria, all right? And it's interesting to look at these. If you look at them, the first 4 are sort of like, okay, these are more personal things, using more larger amounts in longer period than intended, wanting to cut down, but not being able to, craving the use. And then you start to get into 5 and 6 and 7, where it's impacting your community, the people around you. You're starting to not really interact the same way. And then the last few, 8 and 9, really is physical harm. You continue to use them despite danger. I would argue that most of the patients that we see for whom which opiates are failing, we could say the first 2 criteria are met, right? You're using larger amounts for a longer period than intended. And then secondly, you want to cut down, but it's hard to. So, if you think about it, a lot of these patients that we see meet at least the mild criteria for opioid use disorder. Why is that important? I think that's important because it allows us to, hopefully, if we're licensed to do so and we're experienced in doing so, access buprenorphine if we need to for the use in these patients. It's hard to label these patients, addicts, and they don't like to be labeled addicts, obviously, because of the stigma attached with it. And often, when I see these patients, I will, as their diagnosis, put down chronic pain disorder, chronic pain syndrome, which is a ICD-10, and then I'll say chronic use of opioids, chronic continuous use of opioids, which I think most of the time will work with insurance companies to get them Suboxone. But I will always document how many of the criteria they meet in my note in order to argue with insurance companies if I need to regarding Suboxone. And then finally, our treatment goals being achieved. I would say that a good scale that we've started to use in PAMF is this PEG scale, pain, enjoyment, and general activity. There's a lot of different tools out there to measure how people are doing on their chronic pain, but I like this because it's pretty short. I've sort of memorized it now, and it's easy to memorize. And it's basically, we all know the 0 to 10 scale. The first one is that basic 0 to 10 scale. Second is, okay, I go, thinking about that pain that you just told me about, how much does that pain interfere with your enjoyment of life? And that gets a quality of life. 0 to 10, 0 being no interference, 10 being you have no enjoyment at all in life. And then the third is, okay, thinking about that pain, how much does that pain interfere with your general activity? And that gets at function. And so 0 is, no interference, you can do anything you would have done even though you had the pain. And then 10 is you can't do anything. If it was 10, they couldn't come in to see me, right? Because you can't do anything, you have no function. And so it's fascinating to me that patients have a hard time with these scales, don't they? It really is hard to get them to give you a number. Oh, it varies, up, down. Some days 10, some days 4. But I try to push them, and mainly the reason I do it is because I want to see if we can impact things over time. So can we change the PEG score? And what you do is you add these numbers up, so you get the scores and you add them up and average them, and that gives you a number that you can follow over time. And that's what I like to do. But sometimes it's like pulling teeth, I think, to get them to really commit to a score. And then what is an adequate trial? The committee struggled with this, the coalition, because how much should you be and how long should you be able to be on it? And this is not based on necessarily any science, but this is just what the SafeRx committee work group came up with, which is, based on the CDC guidelines saying at 50 milligrams morphine equivalent per day. Above that, what happens? Well, probably you're not going to get much extra benefit, but risks start to go up quite a bit. And I tell patients that when we talk, I go, the CDC says at 50 milligrams, we need to really be sure, okay, that at that point, you're getting benefit, enough benefit to warrant the risks. And if we have to go above that, we got to be aware that the risks are much greater than probably any added benefit. It's hard when patients come to you, isn't it, when they're on 200, 400, 1,000 milligrams already. What do you do then? That's hard. Go down, hopefully. But again, this is a nice tool because it says, okay, what's our target when we come down? 50. You know, you try to get down to a level that perhaps the experts have told us at the CDC that the benefits, if you're getting benefits, are not outweighed by the high risks of overdose or other problems. Okay? And then how long is an adequate trial? And the committee, the work group said 45 days. And the reason we came up with this was, you know, there's data that suggested if at 30 days on opioids, if you were started on opioids and you're not getting good relief at 30 days, you're probably not going to get good relief ever. And then Dr. Lemke mentioned 3 months or 90 days. That's often been thrown around about chronic. You become chronic at 90 days. And there's good data to suggest that if you're on opiates at 90 days, you're probably going to be on them at 3 years, 5 years later. But we said, well, it's hard to get to 50 milligrams of morphine equivalent with, you know, sort of our busy schedules within 30 days. So we sort of compromised and we said 45. Again, no science behind it, just sort of what the committee came up with. But a nice guideline to sort of say, if you're not at a good dose that's working for you at 45 days, you're probably not going to get there. All right, now the next few slides I'm going to go through just talks about what we're doing at PAMF in terms of assessing opioids. We have a service called the Opioid Assessment Service, and the goal is to really try to provide some relief to our overburdened primary care docs because it's hard. These patients are challenging, and they take up a lot of time. And so what we do is we request a PCP referral, and we have different physicians through PAMF that are willing to see these patients integrated into their clinics, and they do an assessment. And I'm going to go over, then what we do also after we see them, we collect data. We collect data with regard to, do they meet the definition of opioid failure? And then we bring it to a group, a multidisciplinary group, and we present the case, and we say, what do you think? Is this an opioid failure or not? Now, one of the struggles we've had a little bit is to call someone an opioid, or that the opioids have failed them. Are we obligated now to say, okay, we have to get you off? So the way we've gotten around that is we've said, your current opioid regimen has failed. So if you're on 100 milligrams of morphine a day, it's not working, we think that current regimen has failed. The goal isn't necessarily to stop your opioids, but to get you down to a dose that might be the risk, a better, more favorable risk-benefit ratio. And that helps, I think. So, you know, I'm going to tell you this, this is sort of what we do in the Opioid Assessment Service, more to give you ideas about how you might evaluate your patients, or maybe in some of your healthcare systems, it sounds like you're doing some innovative stuff in Natividad and other places, you might want to integrate some of these concepts that we've learned, lessons we've learned. So, I've already mentioned about the story, and I think it's important to allow patients to tell their pain story when you first see them. You know, when did you get on opioids? How long you've been on them? What worked, what didn't? It's fascinating to me how often that story is very vague when you ask patients finally, because they often don't get a chance to tell their story, because we have an hour to see these patients. It's sort of a luxury. And so we say, tell me your story, and they sort of don't know what to say because they're not used to being allowed to tell their story. And I really have to push them to tell them the details. What happened next? What happened next? But then they get going, and it seems to work a little bit better after they've gotten a chance to talk. Try to clarify the opioid specifics. I think it's good to do morphine daily equivalents when you assess them. And it's important to look at other meds too, and how those other meds are used. Because again, they're often listed in their med list, but they're not really clear about how they're using them in the detail. You know, you might have you know, clonazepam available, but how often do you take it? And what I've been seeing lately is often, only take it rarely. But here is where it's very important, I think, you know, to look at, I'm going down here, the cures report. Because the cures report tells you a lot. If someone says, I only take 1 clonazepam a day, but they're getting 90 a month, what happens to the other? You know, so I'm learning to check ahead of time. Because I can say that, you get 90 a month and you're filling them every month. Are you saving them? Some people do, a lot of people do. You know, are you selling them? No, they're not going to tell you that. But it's important to be aware of that, okay? The other thing we do, let's see, is I like to ask them about not only about their pain, but also about their perceived side effects. Because I think that's helpful to say, you know, do you attribute your falls, do you attribute your cognitive decline to opioids or something else? If they really attribute it to opioids, they're a lot more motivated to change and get off. If they're saying, oh, it's something else, they're less motivated. So it's helpful to know. And then talk about things that we know are related to opioid use: sleep apnea, falls, irritable bowel or narcotic bowel, abdominal pain, constipation in their past medical history. suicide, depression, not only in the patient themselves, but also in the family. We know more and more now that so much of opioid use disorder is hereditary genetic. So 50% of the risk, we think now, is related to that. So if you have multiple family members who have had problems with alcohol or substances, and you're on substances yourself, it's very important to know that. And then one of the things that we've added to our questionnaire is we do this ACE survey, which is Adverse Childhood Experiences Survey. It was pioneered in Kaiser, and I think it's a valuable tool. It's a pretty simple tool. It's hard sometimes to ask because they're hard questions. You know, one of the questions is, you know, before the age of 18, did someone, you know, molest you, touch you in a sexual way, or, you know, against your will? I mean, it really asks some tough questions. And so I'll often say to the patients, you know, these questions are hard. If you don't want to answer them, that's okay. But it helps us to understand the trauma of your life that could lead to the use of these substances in an inappropriate way. So we ask the questions. And it surprises me, patients, it's happened not more than once that patients will say, no one's ever asked me about this. And this is the first time I've ever told anyone. And so, you know, a lot of the life trauma, I think, is what drives the opioid use in some of these patients. You know, when I have a bad day, I go home, have a couple beers. No, not really. I do sometimes. But, you know, I know I mean, it's I had a bad day, have a drink, you know, but it shouldn't be a pattern. If it got to be a pattern, it would be bad. But if you have the option of, you know, taking your Norco or an extra dose of Norco to help you deal with the pain of life. Again, these patients are survivors. They're strong. They're doing whatever they can. So this is a coping mechanism, just like it is to go on disability. If you can't get a job and hold down a job, and someone will pay you money to be on the couch, that's a smart person that'll do that. So it's important to know what's going on. That Adverse Childhood Experiences score really does help guide us, and we know that, interestingly, not only do answering more yes to four, there are 10 questions that you ask. One is, was anyone go to jail? Did your parents get divorced? Were you beaten? Things like that. And if you answer yes to more than 4 or 5, the risk really goes up quite a bit for adult addiction. Fascinating, I think it is that it also increases for diabetes, heart disease. A lot of things go up when you have a lot of childhood traumas. And then we talk about, let's see, and then we summarize the opioid-related behaviors and look through the chart for them. Most patients aren't going to tell you about their aberrant behaviors. You have to look for them in the chart. So if someone's showing up frequently for refills at the urgent care for their opioids or asking many different doctors, in our electronic health record, we can search through and click on filters. So we can click on urgent care, and I can see how many times these patients show up in the urgent care. We can look at their med list. We can look at past medication. We can look at comments that are made about behaviors, you know, in different notes. So I'll screen through notes. But it helps give us a sense about whether aberrant behaviors or inappropriate use is occurring. And sometimes patients will volunteer things too that are inappropriate, like, oh yeah, I save up my opiates, you know, because I don't want to run out of them. And then we document for the board review questions around whether or not opiates have failed, any serious adverse events, any aberrant behaviors or inappropriate use, and are they meeting goals of care? And we meet monthly to talk about these cases. The problem is there are too many cases to talk about. We are now booked up through September to try to deal with this issue, you know, within PAMF. We need more doctors to do it, So we're trying to think about how do we train people outside of this opioid assessment service program to do these same evaluations. And I'd be glad to, if anyone's interested, to offer to talk more about the assessments that we do and share with you about, you know, outcomes, and I'll talk a little bit about that. Okay. So how do we deal with it when patients have failed opioids? I really think that this is something that we've talked about in our work group at SafeRx Santa Cruz. And these are the core things that we think that you should look for or try to aspire to deal with opioid failure. Provider competencies are such that we want to make sure that, you know, providers should really be able to understand addiction as a disease, like Dr. Lemke said, even if you don't believe it. And guidelines to support ongoing patient engagement, I think, are helpful. With that, by that I mean, what do you do when you want to fire a patient? You know, what are the guidelines for that? I think that's helpful to have in your system, you know, because we really shouldn't just cut people off like one of the videos. We need to engage them. We need to talk about what are we going to do. We need to be able to prescribe naloxone for patients for whom which we feel that opioids are working, Or patients who were weaning but are on a high dose and it's going to take them a year to get off. So get them Narcan at home to be used and train them how to use it. Support for interdisciplinary communication, I think, is a real standard too, to talk among ourselves. Between the therapist, if you have integrated behavioral health, yourself, physical therapist, improve that communication. And then, because these patients really can drain you, to take care of yourself and to do some wellness activities and recognize that that's important. We need to understand how to wean. And Dr. Lemke talked a little bit about that, but tapering plans and weaning is important. That's a whole lecture in and of itself, but know how to go down. We unfortunately don't have a lot of good data on how to wean. But go slow, take it easy with patients, support them as you're going down. Access to medication-assisted treatment we're working on to try to improve access to buprenorphine. How many buprenorphine providers are here? Raise your hand. So there's quite a few. Probably most of the county is here because there's not that many in the county. But it's important to try to expand that, to get people experience. One of the things we're doing in Santa Cruz is we're going to start a buprenorphine prescribers support group, or not support group, interest group, where we're going to get together, talk about difficult cases. How do we do it? Do you induce at home? Do you induce in the clinic? How do you do it? Do you do different tricks to help things work? And then to really understand when perhaps buprenorphine may not be the ideal medicine, but that methadone might be better. That's an important thing, because you do really have to have access to addiction specialty treatment if you're going to address opioid failure, and know where your addiction services providers, Janus, the camp, Encompass, all the programs that do, Beacon House, that do a good work in this area. We're actually pretty fortunate to have a lot of good resources on those lines. And then behavioral health services are vital. And we're still struggling with this. I think we're struggling even with integrated behavioral health in some of our healthcare settings. How do we build linkages between those groups? Because these patients have a lot of life trauma that need to be addressed. How do we address that life trauma? I'm not very good at it as a doctor. I wasn't trained. I need to use my colleagues in behavioral health counseling services to help with that. I feel that more and more strongly that it's easy to give buprenorphine, but we need to make sure that they have access to good behavioral health as well. Methadone, I think, might be preferable, just a few comments, when daily supervision is needed. Because with methadone clinic, patients have to show up daily. So it's important to realize if someone has a poor psychosocial situation, a lot of stressors, instability, poor support, methadone might be a better choice. And it's okay to tell someone, I think that's the whole struggle with talking about addiction or not, but to say, I think this is a big problem. I want what's best for you, and I think what's best for you is to get you into the methadone clinic. But other patients, buprenorphine is fine, as long as we have good counseling support along with that. And clues might be patients that are missing appointments a lot, that have really a lot of psychosocial stress. Some patients will tell you I'll stop my Suboxone a few days and then use drugs and then go back on them if they're using illicit drugs. But that's harder to do in someone that's on prescription drugs. And then patients who don't tolerate Suboxone well. And some patients really get nauseated and have headaches and don't like it. All right. I think we need to insist that we have good access to good physical therapy and functional restoration programs. In PAMF, we're struggling with that because we don't have the capacity to deal with all these chronic pain patients. And just like sometimes it's hard and we have to tell ourselves to turn into the pain of these patients, we have to ask our physical therapy colleagues to turn into the pain of caring for these patients as well, because they're hard to care for and they're hard to deal with. And then we need to have access to complementary therapies. If we're going to take away opioids, sometimes we can give Suboxone as an alternative, but sometimes a better alternative would be, or in combination with it, would be things like acupuncture. And we're going to hear later today about that. But I think this is important to build the resources in the facility to be able to do that today. And then subspecialty pain resources, we're going to have, Gabe, who's going to speak next, is going to talk about how sometimes non-opioid therapies are good, and interventions, sometimes procedures are good too. I know we sort of criticize sometimes too many procedures in the pain clinics, but sometimes they are very helpful. And those need to be considered, and we need to have access to them. There's really only 4 paths to take if you think about this. And I think this is my last slide, right? Time's up? All right. Is this, and I want you to think about this. To go up, there's 4 paths to take when patients and opiates have failed. And it's important, and I go over this with patients, and I think it does help them to understand, because we go through it, click it off one by one. So we'll say, okay, you could go up on your opiate dose. That really is no opportunity anymore. Because no one's going to do that, right? Because in our new environment, we're not going to go up. We used to do that all the time, and here I use it as an opportunity to apologize for the healthcare system. I'm sorry we did that before, but we can't do that anymore. If you're on a high dose, it's not working, it's a lot of side effects, it's not going to work. So that's off the table. So, okay, now we're down to 3 choices. The next thing you could do is stay the same. Well, how's that working for you? I mean, that's why you're here, right? Because it's not working, or why your doctor sent you here. It's not working. So that's not really a good choice either, right? And sometimes, sadly, patients will say, oh, yeah, but that's what I want to do, because they're too scared. But I think it's important to acknowledge, okay, let's give you some time. If you change your mind, let's talk some more about maybe other options. And sometimes patients will, 3, 4, 6 months later, come back to you and say, okay, I'm ready to do something else because this isn't working if the doctor won't let me go up. So then we're left with 2 choices. Go down on your dose. And I'll often say to patients, okay, up, it's off the table. Stay the same, it's not really good. What else? And they'll say go down. I'll let them say go down because it helps them take part of that decision. And that's weaning, right? And so I say we can talk about that. And we talk about how often doctors wean too quickly. This is going to be a slow process. We're going to support you and try to really take away some of the fear and try to let them say, we want to let you take this, set the pace of weaning. But I think weaning's tough. I mean, it's really hard to do. Some patients will do it if they're really motivated. But, to spread something out over a year, that's hard to do. When every couple weeks you're feeling a little sick for a week or 2, and then you just are feeling better, and then we drop you again. That's tough. But some patients can do it, and the strength is amazing of these patients. And then switch to another medication, and that would be buprenorphine, or methadone. And we talk about that. Buprenorphine's a great drug, I think. It can be a little expensive, but it usually is approved by most insurance companies. It does a lot in terms of reducing your sedation. It's hard to overdose. There's some evidence now that it can reverse some of the tolerance and hyperalgesia that occurs with opioids. And I tell patients, this medicine helps your nervous system swing back in balance because it's gotten out of balance by using opioids for so long. Buprenorphine can help it swing back. The problem is, are we going to create a whole cohort population of people on Suboxone now instead of opioids? And there'd be worse things. I mean, I'd rather have someone on 16 or 8 of buprenorphine than 100 of morphine. But still, it'd be nice to think that over time we can wean down the Suboxone. And sometimes you can. Sometimes over time people miss their doses of Suboxone and we can start to cut back the dose that they get. And so I tell patients all that. And patients want to try it. It works for a lot of patients, but not for everybody. So we had 63 patients referred in. We looked at this data recently. 63 patients were referred in 2016 to our opioid assessment service. And 2 weren't even on opioids, so I don't know how they got into our. But we talked. We talked and visited. The doctor wanted to put them on opiates, and I think they were asking, was it appropriate to put them on opiates? 13% or 13% we thought didn't really have opioid failure. They were doing okay. They were in that population that probably were doing okay. Low dose, stable, weren't showing adverse effects or aberrant behaviors. But 84% really, we thought, met the criteria for opioid failure. So that's a pretty big percent. But, we're selected to, the primary sent them to us. And then of those, 17% after the first visit never came back. Not that they didn't come back to our healthcare system, they just didn't come back to our clinic because they didn't like what we had to say. When I go back and looked at the data, looked at the patients, and they're still seeing the patients primary, doctors still following them, and the primary is struggling with them. They keep coming back wanting early refills, so they really have had opioid failure, but they're not wanting to deal with it. And then 57% 26% were weaned. Isn't that surprising? A quarter of the patients were able to wean, which surprised me. I didn't think we'd see that high a number weaned. And a lot of these started weaning before they even got to the opioid assessment clinic, because the primary doctor took the time to have a conversation. These don't seem to be working. Let's start weaning. And so they started the process. And then we kept doing it. 57% were changed to buprenorphine. So that's over half went on buprenorphine. And of those, only 4 or 13% really failed buprenorphine. What is failure of buprenorphine? They just didn't like it. It didn't help their pain like I said it would. Because a lot of patients who switch to buprenorphine have a reduction in pain levels too. and they wanted to go back. But when they went back on their opioids, I certainly wouldn't put it back if they were having serious adverse events, but it's more they failed previous opioids because it wasn't giving them good analgesia or good function. So we allowed them to go back on their opioids, and half of those, or 2 out of the 4, were on lower doses. 2 stayed on the same dose of opiates. And then most of the patients stayed on a stable buprenorphine dose, but that's only been a year. So maybe those can wean down like the other 20% did over the first year. So encouraging data, preliminary data, but it shows you that patients can wean, they can switch successfully to buprenorphine, and even though opiates have failed them, hopefully our healthcare system hasn't. Thank you very much.